going to discuss on the
This
topic of
meeting is
diabetic
being recorded.
retinopathy. Today we are going to focus mainly on signs and symptoms and pathogenesis and classification of diabetic retinopathy. And first we are coming to the risk factors of diabetic retinopathy. The most important risk factor is the duration of diabetes mellitus. In a study, it states that after 20 years of diabetes mellitus, in type 1, there is 98% of chance, and in type 2, there is 60% of chance in which the patients will develop some form of diabetic retinopathy, and out of which, in which 53% in type 1 and 5% in type 2 will have proliferative diabetic retinopathy. And the second most important risk factor is the glycemic control. The diabetes control and complication trials have done a study mainly in type 1 diabetes mellitus. In that study, the study and control group have been divided, in which the study group is the tight control group, in which the patients had a good glycemic control, in which the HbA1c was less than 7.5%, and the standard control group has HbA1c more than 9.5%. And the study results found that at the end of 3 years, the risk of developing diabetic retinopathy decreased by 75% in patients who had controlled HbA1c, and out of which there is 50% reduction in the rate of progression to proliferative diabetic retinopathy. And the study tells that for every 1% reduction in HbA1c, there is 35 to 40% reduction in the progression of diabetic retinopathy. And the next risk factor is the puberty. This comes into play mainly in type 1 diabetes mellitus. In puberty, the development and progression of diabetic retinopathy is noted. This is mainly because of increased insulin-like growth factor. This is because the insulin-like growth factor usually causes alteration in the blood flow, and the main important thing is the normal autoregulation in the retinal blood vessels is lost because of the insulin-like growth factor, and which results in the transient ischemia, and which results in the diabetic retinopathy progression. And the next important risk factor is the hypertension. As we all know, diabetes, hypertension are comorbidities. Mostly they coexist with each other. In patients who have tight blood pressure control, there is 37% decrease in the microvascular complications in the diabetic retinopathy. And they have also found that the requirement for the laser photocoagulation has also been reduced in patients who had a hypertensive good control. The next risk factor is the elevated serum lipids level. And increased serum cholesterol and LDL is associated with increased severity of retinal hard exudates, and that itself results in diabetic edema severity. And other risk factors are pregnancy, obesity, smoking, and cataract surgery. In diabetic retinopathy, mainly with macular edema, if cataract surgery is done, there is high chances of progression of macular edema. Next, coming to the anatomical factors. Anatomical factors play a key role in the microvascular complications of diabetes mellitus. And in diabetes mellitus, mainly due to hyperglycemia, there is loss of pericytes in the capillary wall. This loss of pericytes usually causes capillary basement membrane thickening, which results in the acellularity of the capillary wall, which ultimately results in the breakdown of blood-retinal barrier. And there are many mechanisms, biochemical mechanisms, that have been stated in the pathogenesis. The main mechanisms are, the first is the aldose reductase theory, the next is advanced glycation end product theory, the theory, the reactive oxygen intermediates theory, protein kinase C theory, and insulin receptor and glucose transporters theory. And the main culprit, as you all know, is the hyperglycemia, which activates the polyol pathway and advanced glycation end products and protein kinase C activation, oxidative stress. These are the main things happening. The polyol pathway is otherwise called as the sorbitol pathway, and these things actually does two things. One is the vascular endothelial dysfunction, which causes microvascular occlusion, resulting in ischemia and neovascularization. The other thing is activation of cytokines and growth factors. This actually increases the microvascular permeability and causes diabetic retinopathy. Now coming to the polyol pathway, that is the sorbitol pathway. Now glucose is usually converted to sorbitol using an enzyme called aldose reductase, and sorbitol is converted to fructose using sorbitol dehydrogenase. And what happens is in hyperglycemia, more of glucose, more of sorbitol is produced, but the enzyme sorbitol dehydrogenase is in very minimal quantity or even absent in the retinal cells. As a result, the sorbitol is not converted to fructose and the sorbitol is getting accumulated inside the cells. This sorbitol, what it causes is it usually drags water from outside, and this results in swelling of the cells, that is osmotic damage of the cells, which ultimately results in the cell death. Next comes the protein kinase activation. The diabetes not only cause advanced glycation products, but also causes diacylglycerol generation and oxidative stress. This ultimately results in the protein kinase C activation. What does this protein kinase C do? It usually increases the vascular endothelial growth factor and it also causes microvascular damage. Now researchers say that there is a drug, ruboxystavin, that usually prevents the action of the protein kinase C and which decreases the progression of diabetic retinopathy. And this slide actually summarizes the causes of retinal ischemia, not only diabetic retinopathy, overall the cause of retinal ischemia. First, there are changes in the blood flow. There may be increased flow, increased viscosity, or increased hematocrit. Then the changes in the erythrocyte itself that cause increased aggregation or decreased deformability, or changes in the plasma, that is hypercoagulation or decreased fibrinolysis, or changes in the blood flow, which results in increased hydrogenase or increased aggregation, which usually results in the capillary occlusions, which results in ischemia, which causes the stimulation of the VEGF, which causes neovascularization, and if that is in the iris, that can progress to neovascular glaucoma, and in the retina, it causes or retinal hemorrhages, vitreoretinal gliosis, and detachments, and diabetic retinopathy. It can cause proliferative diabetic retinopathy and advanced diabetic eye disease. And also, these first risk factors can cause retinal hypoxia directly. Then additional factors such as increased von Willebrand factor, increased thromboxane, decreased prostacyclin. These factors also cause capillary occlusions. Now next, coming to the signs of the diabetic retinopathy. The earliest and the most important sign is the microaneurysms. As we already discussed, in diabetes, the anatomical risk factors, that is the capillary wall pericytes, are absent. So the capillary wall itself is weak, which results in the focal dilatation of the capillary wall, and that results in outpouchings. And this outpouchings is mainly saccular, and that is called as the microaneurysms. These microaneurysms mostly develop in the areas adjacent to capillary non-perfusion, and that is mainly in the inner capillary plexus, there is ganglion cell layer. This loss of pericytes may also lead to endothelial cell proliferation with the formation of cellular microaneurysms. Now, this microaneurysms may either leak plasma constituents into the retina because of the breakdown of the blood retinal barrier, or they may thrombose. As we already mentioned, this is the earliest sign of diabetic retinopathy, and they appear as tiny red dots. They start initially temporal to the fovea, and the most important point is it is very difficult to distinguish clinically from dot hemorrhages. And to distinguish them, we have to take fundus fluorescent angiography. And in fundus fluorescent angiography, microaneurysm appear as tiny hyperfluorescent dots, and they're usually numerous. And in late frames, the microaneurysms usually don't show any leakage. But in hemorrhages, we can see the hyperfluorescent dots in the late phase. It's increasing in, and that is leakage happening in the late phases. And here we can see this fundus photo depicts the numerous microaneurysms and dot hemorrhages. And if we see fundus fluorescent angiography, the microaneurysms usually don't leak, and the hemorrhages which already there usually called a blocked fluorescence, blocked choroidal fluorescence. And next, coming to the retinal hemorrhages. The retinal hemorrhages may occur in the varying layers of the retina. First, we are coming to the retinal nerve fiber layer, and the hemorrhages arise as large superficial precapillary arterioles, and they assume their characteristic shape because of the nerve fiber layer character architecture. And next is the intraretinal hemorrhages. They arise from the venous end of the capillaries and are located in the middle layers of the retina, mostly outer plexiform layer, and they form a dot configuration. And deeper dark round hemorrhages, they usually represent hemorrhagic retinal infarcts that are also located in the middle layers of the retina. And the extent of the involvement of the hemorrhages is usually a significant marker for the progression of proliferative diabetic retinopathy. And here we can see the various lesions and the affected layer, cottonelle spots in the nerve fiber layer, microaneurysms in the inner nuclear layer, dot and dot hemorrhages in the inner nuclear outer plexiform layer, flame-shaped hemorrhages in the nerve fiber layer, and hard exudates in the outer plexiform layer. Now next coming to the exudates. Hard exudates, they're usually chronic localized retinal edema that is the cause of this, and they develop at the junction of normal and edematous retina. They are usually composed of lipoprotein and lipid-filled macrophages. They are located in the outer plexiform layer, and hyperlipidemia is a major cause for the exudate formation. And they usually appear as waxy yellowish lesions with relatively distinct margins that may be in clumps or rings at the posterior pole. They usually surround the microaneurysm. With time, the number may increase and the size also tend to increase, and fovea may also get involved. When leakage ceases, these exudates absorb either spontaneously or they take over a period of either months to years, either into a health, they are observed either by healthy surrounding capillaries or by phagocytosis they have been observed. Chronic leakage usually results in the portion there is crystalline cholesterol formation. And FFA is usually commonly done, and it also hypofluorescence with large dense exudates. Since it is an exudate, usually blocks the background choroidal fluorescence, but the capillary fluorescence is generally preserved, overlaying these lesions. And here we can see in this second image, we can see the hard exudates, and along with that, hemorrhages are also associated. With time, the crystalline cholesterol deposition, as we see in the last picture, it is formed. And next, coming to the cottonwool spots. The cottonwool spots are composed of combination of neuronal debris, as you already mentioned, that is in the nerve fiber layer, and they result from ischemic disruption of the nerve axons. The swollen end, which is known as the cystoid bodies. As these cottonwool spots heal, the debris is removed either by autolysis or phagocytosis. These appear as small, fluffy, whitish superficial lesions that usually obscures the underlying blood vessels. They are clinically evident only in the post-equatorial retina because there only the nerve fiber layer is of sufficient thickness for us to see the lesion. And in fundus fluorescent angiography, there is focal hypofluorescence due to local ischemia, blockage of background choroidal fluorescence. And here we can see the whitish lesions which we are seeing in the post-equatorial region. This fundus photo is focused is the thing, and we have been seen associated many hemorrhages, dot hemorrhages, microaneurysms also associated with it. And now coming to the venous changes. The venous abnormalities seen in ischemia consist of generalized dilatation and tortuosity along with looping, beading, and sausage-like segmentation. These venous abnormalities are very important because they usually correlates the likelihood of developing proliferative diseases. And here we can see the third picture is the sausage-like segmentation, and the second B picture is the beading, and the A picture is the looping of the vessels. Now coming to the IRMA, that is intraretinal microvascular abnormalities. These arteriovenular shunts, they are arteriovenular shunts that run from the arterioles to venules, thus bypassing the capillary bed and are therefore seen adjacent to the areas of marked capillary hypoperfusion. In the picture, as you see, there are 5 irregular red intraretinal lines that run from arterioles to venules. The main important point is that they do not cross the major blood vessel. In fundus fluorescence angiography, they show focal hyperfluorescence associated with adjacent area of capillary closure. There is dropout, but there is no leakage. And the main differentiating point from the NVE is that NVE usually crosses the blood vessel and they usually NVEs are very leaky in FFA. Now, next coming to the classification of diabetic retinopathy.
So classification we will take next time.
Sir, okay, sir. Next,
Classification we will take next time. Let's discuss whatever we had now.
okay, sir.
Okay. You people are sitting where
Yes,
in your respective OPDs or retina department?
in a seminar hall, sir.
Huh? Oh,
Seminar
upstairs.
hall in the second. Yes, sir, upstairs.
Upstairs you are sitting. Then show me your
Yes,
faces when you are not in retina department.
yes, sir. Okay, sir.
So all of you can show your faces there. Oh, everybody is there. Everybody is busy in their respective. Could not get connected. Next time we will connect TV, huh? Can you hear me? CB, can you hear me?
Yes, sir. Yes, sir. We can hear you, sir.
Next time we will try to connect on TV. It's okay. It's okay. Now you can now, now you can disconnect the video. It's okay.
Okay, sir.
Right.
Okay, sir.
Next time we will try to connect with TV also.
Yes, sir. Okay, sir.
Okay. Actually, I tried to download your PPT here, but I could not download here. It could not open up. Otherwise, I would be sharing that thing. Uh, we
Sir, which slide, sir?
It's okay.
Hello,
Any
sir.
doubt? Actually, you have explained well fully. Any doubt you people have? First, tell me that. Any doubt you people had?
Sir, Soumya ma'am has doubts, sir.
Sir, hard oxidates will stay for how long? Like after controlling?
After controlling what?
Like, sir, if once like edema also decreases, still hard oxidates will persist or?
Hard exudates keep on persisting. Hard exudates are what? The leakage which is coming along with the plasma.
Oh, okay.
Okay. Once the leakage happens, hard exudates are collecting there. They will not go away.
Oh,
So
okay, sir. Okay.
they will not go away unless what happens is there is a lot of edema and that edema is moving in and out. Normally, what happens in diabetes when leakage is happening, it happens only towards the retina, not towards the blood vessel in the choroid or not towards the retinal vessel. It is only coming out. Okay, either there is lot of retinal edema, then only it can go back. Okay.
Okay, sir.
Only if there is lot of edema, then only it can go back, or you have to give phenofibrates, which can pick up the lipids from the retina. Then only the lipid material will go away. The statins which we gave, atorvastatin or other things, Do not take away the lipids from the retina. They are only for prevention of extra lipid deposition. Okay.
Okay, sir.
Only fibrates will work.
Okay.
Okay. Anybody had any doubt in the pathways or anything? If you see, you can share. You can see the slides now, which I am changing.
Yes, sir. We can see, sir.
Yes, sir.
Okay, like now, all the pathways which you have described here, what is the most important pathway among these? What you feel? Which is the most important pathway which has to be taken care of about all these, like 6 pathways you told?
Aldose relatase, sorbitol.
The most important pathway is the fourth one, okay? Reactive oxygen
Hmm.
intermediate theory. Because
Okay,
this
sir.
this this superoxide theory, the superoxide molecules which are made only are responsible for doing all the things, all the damage. So whenever a patient has diabetes, don't forget to start them on multivitamins also. Okay.
Okay, sir.
So reactive oxygen intermediate theory remains, and that's why many people try to give them even vitamin C and tell that vitamin C their uh, damage is less. And then comes the advanced glycation end product theory, and then the third one is aldose reductase theory.
Sir, any role in zinc, sir, in progression?
Which one?
Zinc in delaying the progression of diabetic retinopathy along with
Any role
vitamin
of
D3.
no, vitamin C has a role, not vitamin D3 directly. Vitamin D3 giving does not help prevent diabetes, but shortage of vitamin D definitely will damage more.
Okay, sir.
Okay.
Yes, sir.
You had explained fully everything. Microaneurysms, as you told that there are 2 types of microaneurysms, always remember. Okay, one is cellular microaneurysms and the other one are leaking microaneurysms. Cellular microaneurysms means the microaneurysms which have a block, which don't leak. So all microaneurysms don't leak. Remember this thing. Okay. And
Yes, sir.
whenever leakage is happening, what will happen on FFA? Hyperfluorescence. Okay. That time you got confused during the slides.
Yes,
Okay.
sir. That I
Whenever leakage is there, there will be some hyperfluorescence.
hyperfluorescence.
So hypo will happen only when there is a retinal nerve fiber layer hemorrhage or pre-retinal hemorrhage.
Yes, sir.
Okay.
Okay, sir.
So anybody else has a doubt? Ramya has any doubt? Ramya just came out of exams. About the cotton wool spots, any doubt? Histology, what you see in the histology? The slide you have kept of histology. CB,
Yes, sir. Histology slide.
this histology slide which you have kept for the exudates, which are the exudates in this?
Sure, sir. Not sure, sir. Beneath the
What is this material? Violet material. Which stain is this? This slide is of which stain? It is hematoxylin and eosin stain now.
yes, sir.
And violet is which one? Eosin or hematoxylin? So these violet things you see in between the cellular layers, the blue are the cellular layers. In between you see this hyaline material,
Okay,
the
sir.
violet one. This one are all hard exudates. The blue ones are cellular layers. Okay. Down the cellular layer you can see photoreceptors and RP and Brooks. In between the photoreceptors and the RP you can see some gel-like material which is called as interphotoreceptor matrix. Okay.
Okay, sir. But-
Venous anomalies are very important to label it as severe NPDR, okay? The looping you had showed is a severe NPDR feature. Okay? The looping which you are showing
Okay,
in
sir.
all these. It does not amount to PDR unless there is NVE. So seeing such a
Yes, sir.
bleeding points or anything, don't label it as PDR unless there is a frank NVE somewhere. It's a severe NPDR feature. Okay?
Okay, sir.
And IRMAs also, how will you know about IRMAs is? It will be connecting artery and a vein.
Yes, sir.
Okay? It will be connecting two major vessels will be IRMAs. If they are not connecting the major vessels, what will be it? NVE.
Yes, sir.
Any doubt? Other people? Classification we will take next time, okay?
Okay, sir. So
Let
that
every
histology slide alone once more, sir.
Okay, sir.
which one?
That histology slide.
Yeah, this one, no?
Yes, sir.
Okay, the blue one, the blue dots are the cellular layer. The
Okay,
in
sir.
the outer layer is very densely packed blue layer, which is the photoreceptor cell's nucleus, which is called as outer
Okay, sir.
cellular layer. And the inner layer of inner cellular layer is slightly away, blue dots. There is a ganglion
Okay, sir.
layer with the foamy. Ganglion cell layer has whitish along with the cellular structures. You could see, na?
Yes, sir. Yes, sir.
Okay. And in between the two cellular layers, you can see a hyaline material which is a lipid. This much
Okay, sir.
lipid gets collected, and it is not very easy for the lipid to go away through the blood vessel because it is aggregated to each other. That's why we have to give phenofibrates if we want to bring these out. Otherwise, we
Okay, sir.
have to prevent more of the lipids collecting there. Okay.
Yes, sir. Okay, sir. Yes. Thank you, sir.
So read about it. Any doubts? Share in the group. Okay. Everybody read about it. Any doubts? Share in the group. Next time we will do the classification part. Okay.
Okay, sir.
You were
Yes, sir.
slow, but you were good. Be slow only. No need to be in a hurry to finish the topic. But be slow, but go into the depth.
Yes,
Okay.
sir. Okay, sir. Yes, sir.
Next time we will do the classification then. Okay.
Okay, sir.
Okay, then we will take a leave. Okay.
Okay, sir.
Thank you,
Thank
sir.
you.
Thank
Thank you,
you,
sir. video